Lopez.
Okay.
And I think that he's 13 years old,
Okay.
and that I think he weighs 20 kilograms, 13 years, and it has a trach.
I'm sorry, Susana, tell me, is
19?
yes, is too weight.
Yeah, I thought she said 20
Maybe.
kilos, maybe more.
Maybe
He's
more.
big.
He's big. It's too big.
He's big,
Yeah.
yes. He has grade 3 subglottic stenosis, okay? And so he's trached so that he can breathe past it.
See?
Okay.
Yeah.
So today, they took him to the operating room, and the first thing they did was they looked with a bronchoscope, and they confirmed that he has grade 3 subglottic stenosis.
See? See?
Okay. When they went to intubate him and they introduced the blade, they had a really hard time getting a good view. Okay. And so they ended up placing an LMA. Do you know what an LMA? A laryngeal mask. Okay. And then they intubated through the LMA using a bronchoscope.
Van a poner el broncoscopio dentro de la máscara laringe.
And that's the first part of the operation, because to do the operation they open up the neck and the trachea and can no longer rely on the tracheostomy tube for ventilation, because that's distal to where they're working. So first they secure the airway from above, then they open the neck and do the surgery. Does that make sense?
Sí, sí.
Okay. So have you taken care of any of the Samantha or Matthias? So what they had done, let's start with what they had done. So if this is the trachea and this is subglottic stenosis, right? It should be wide open here, but it's very small because there's all this scar tissue, okay? So this narrowing, if the patient is lying flat, right, this is the head, this is the trachea, and this is the carina. Okay, this is the trach.
Yes.
This is the stenosis.
Okay.
And when you look down the airway, this is what you see. And this is all scar tissue. So what they do when
Este es el tejido cicatrizal.
Okay, so what they do is they open up the airway, they see the trachea, and they slice into it. And they actually, if they do, they can either, this is anterior and this is posterior. They can put grafts in to now make that hole much bigger. Does that make sense?
Okay.
So that is an anterior graft and that's a posterior graft. Where do they get the graft? It's cartilage that they harvest from a rib. So they always come back with a little incision here with a little rubber band drain, so that if they develop a hematoma, it can evacuate.
Sí, sí.
Tenemos que evacuar.
No,
Sí, hay
va a llevar un
presencia.
dreno para evacuar el hematoma que se va a crear por la excisión de la costilla.
So
Porque
the
ahí han puesto el injerto.
Ajá, de la costilla van a sacar estos pedacitos.
so there's a risk that when they harvest the cartilage, they can give the child a pneumothorax.
Y hay riesgo de neumotórax.
So they thank you. They put like soap suds on and see if there are any bubbles. They in the OR they check, they put like liquid and they see if there's any bubbles.
Okay.
And usually there isn't, and when they sign out to you in the ICU, they'll say, we think it went well, breath sounds were equal when we left the OR, but your first job is to call for a stat chest x-ray to make sure that there's no pneumothorax.
Tu primer trabajo es tomar radiografía de tórax para descartar neumotórax por la herida de la toma de
¿Tú
mujer.
entendés ahorita la traducción?
Yo le estoy traduciendo.
Después lo dejo. So, if the patient is breathing spontaneously and has a very small pneumothorax, we just watch them.
Yes.
But if the patient is having positive pressure ventilation, we know, right, that a small pneumothorax is likely to become a big pneumothorax, and we might decide to put in a chest tube.
Okay.
Okay. So, there are two incisions, one in the neck and one in the chest, okay? So there are some patients who only get an anterior graft and others who only get a posterior graft. I think that Matthias just has posterior, right? It doesn't really matter for you and me. It doesn't matter so much. So this has to heal, and it will have a tendency to close down
again.
unless there's some kind of a stent in there allowing it to heal without closing down.
Le ponen un stent para evitar que se colapse por la cicatriz que va a haber. Por eso no lo podemos intubar.
So there are different types of stents we use, and both Matthias and Samantha have what we call a floating internal stent. Floating because it's not really attached to anything. It's actually an ET tube, just cut. It's just a plastic tube in the airway, right? So if this is where they do the surgery, it's sitting right in there, and then it's sutured so that it doesn't fall down into the airway.
Okay.
And Matthias, he has just a single suture right here.
Yeah.
Okay. And in a week, he will return to the operating room. He will get bronched, and if he's healed well, they will take a pair of McGill forceps, grab the stent through the mouth, cut the suture, and pull the stent out through the mouth. It's brilliant, right? It's pretty cool. Yeah. For this 1 week while they're in your unit healing, it is very important that there's no air that's allowed to escape, because this is a fresh suture line, right? So if there's any air that let's say that he's breathing like this, if the air is allowed to escape here, it can come out, and you'll feel it, and it's subcutaneous emphysema. You can feel crepitus.
Yes.
And when it's really bad, you'll see the neck will get big, and it will track up into the cheeks, down into the chest. Very bad, right? So the other number 2. So number 1 was to check for a pneumothorax.
Yes.
Number 2 is to check every hour. Takes 2 seconds. Just feel, is there any buildup of subcutaneous emphysema?
Yeah.
If you're worried, get an X-ray.
Ahora.
If you're worried, get an X-ray. The other thing to do is to make sure this trach will have a balloon. Make sure that balloon is inflated.
Okay, this is the reason.
That's the reason.
This is one reason.
Yes.
Okay.
So it's all of our patients are breathing spontaneously, so it's not as big a deal. They're sucking the air in. The air is likely to go there and not around.
Yes.
But for any patient that comes back and who is requiring positive pressure ventilation, that's now air being pushed in. It will go the path of least resistance. And so if for whatever reason the lungs are not compliant, it's going to want to escape here. And so you have to make sure that you always have a seal.
Okay.
Does that make sense?
Yes. What
Okay.
happens if the balloon is break down?
It would need to be
the
replaced, and we
replaced.
would do that with the airway team.
Okay.
If we are told that this is a fresh trach, but for him, I think it's a mature stoma,
Okay.
and
yes.
so you could probably do it yourself.
Okay. Okay.
We can
Maybe
talk about
maybe use
in
2
in
plus
an
balloon.
yes, in an emergency, and that's why you see taped at Matthias's bed and Samantha's bed. Yes, they have an extra trach, but they also have 2 ET tubes with a cuff.
Okay.
And in an emergency, it wouldn't go in very far, right? Because you're right by the carina, but you would just
Yes,
put
it's
it in a little
near.
bit, blow the cuff up, and call.
Okay.
Okay.
O sea, solo lo metes y lo inflas cerquita porque ya está cerca la carina. Si no se va a ir a un bronquio.
Okay. So a couple other important things for this patient. Everybody on the team has to understand that even though you can't see it, there's a stent in there. So these patients are not bagable or intubatable from above, because what would happen?
Repeat slowly, please.
So even though you can't see that there's a stent in here.
Yes.
Everybody has to know that there's a stent in here. So you can't bag. You could push that stent down.
Okay.
And you can't put a breathing tube in. It will hit the stent.
Okay.
So the patient's
Aunque-
only... Yeah, go ahead.
Okay. Aunque no lo veamos, hay un stent aquí. No le podemos dar con la máscara porque desplazamos el stent hacia la carina o el bronquio y no le podemos poner un tubo porque va a chocar contra el stent. Así que la única manera que tiene él es a través de la traqueostomía. Okay. Y el estómago de él es bien grande, el del niño.
So that's what this having this trach in place, this is the patient's, like Matthias's only airway.
Okay.
So number 3 important thing. So number 1, pneumothorax.
Pneumothorax.
Number 2, crepitus. Number 3, you have to make sure that the secretions are not able to be super thick and pluggy. Because if he plugs, mucus, like a big mucus plug,
Tapón.
that occludes.
Okay, tapón.
Okay,
Tapón.
so that's why you see that they all have humidified
Yes.
air.
Okay.
Your environment is quite humid,
Uh-huh.
but in Boston it's very dry,
Okay.
and it's a big problem unless we maintain good humidification.
Aquí nosotros tenemos un ambiente muy húmedo que nos facilita que el moco esté fluido, pero en Estados Unidos, en Boston, donde ellos es muy seco, entonces ellos ocupan dispositivos para humedecerlo. Pero le vamos a poner el Mindray con la cascada para que esté húmedo, esa terapia respiratoria. I talk about the therapists use a Mindray ventilator to humidify.
Yes,
Humidity.
to humidify. That's why,
Humidify
yeah.
the airway.
Exactly,
Okay.
so it's a little bit of a weird setup. You have the ventilator there, but you're not ventilating, you're just using
Only
its
venti-
ability to humidify the air.
Yes, that's
Okay, and then the respiratory therapists have to be very vigilant about suctioning. Not ever past the tip, because then they'll hit the carina, but just to make sure that's patent.
Okay. Que esté
Especially-
permeable el
yeah.
tubo, ya saben ellos. ¿Verdad? No van a pasar porque si no golpean la carina, solo para que esté permeable la cánula de traqueostomía.
Okay.
Okay.
Okay. So number four, having this stent in your airway, especially if it's a little bit high, can make you very nauseous and cough. Nausea?
Ese ruido y tos, like croup.
Yeah. Mhm.
Okay.
And so giving them, I don't know if you have like ondansetron or some
Yeah,
kind of
yes,
antiemetic.
we have.
Yeah, okay. So I'm
Le
going to
pones
give this to
dignidad,
you.
una vez para empezar.
Okay, so we've talked about humidification and nausea, and we've talked about secretions, pain management. So for the first 24 hours, you just want them to be on standing IV Tylenol, like every 6 hours.
Okay.
Okay, and then what we've been doing is on the first overnight, dexmedetomidine
Yes.
and a very low infusion of morphine.
Yes.
When we tried intermittent morphine for Matthias, it wasn't enough, and so he went on a low infusion.
Okay. Una infusión de morfina, dexmedetomidina, paracetamol. Y si querés tramitar para conseguir ondansetron o granisetron para tenerlo ya listo, porque ya no lo digo, mejor tengámoslo listo.
But it's a balance. We want them calm and sedated, but breathing spontaneously.
Yes.
Because to put them onto a ventilator is very dangerous for 2 reasons. Number 1 is this issue of positive pressure, right? Is you worried about subcutaneous emphysema? And number 2 is if you have the patient's trach hooked up to a vent and they're not deeply sedated and they move, they're at risk of decannulating. So
Sí.
it's much safer for them to be breathing spontaneously.
Sí, sí.
Okay.
Sí, dos cosas. Sí. Si lo conectamos al ventilador, se puede canular si él se mueve. Pero tiene que estar súper bien sedado. Y lo otro, que la presión positiva va a hacer que haya fuga de aire dirigida a la reparación de la tráquea. Entonces vamos a tener enfisema subcutáneo.
So all of these things I've told you relate to Matthias and Samantha. The patient that you're going to be taking back tonight is a little different. So now I'm going to tell you what makes him different. Okay? The reason this is called a 2-stage repair is that the first stage is this. After he goes to the operating room in 1 week and has the stent removed,
Okay.
he'll go home with the trach still in place.
Okay.
And then he'll do like capping trials
Te van a tapar la traqueostomía, te
and
van a
see
fluir.
how he breathes. And then before Dr. Bonilla will decannulate, he'll probably have him come to your unit to spend a night capped overnight with a sat monitor on to make sure that even during sleep he's breathing well.
How long?
Overnight.
No,
Like one night.
yes, but how long the operation room to decannulate the patient?
So it's a great question. Sometimes it depends. Like in Boston, I know Dr. Hartnick doesn't always like to decannulate in the middle of winter when we have tons of respiratory viruses.
2 or 3 months?
So it can be somewhere between 2 and 6 months.
Okay. Entonces, en 2 o 6 meses probablemente el doctor Bonilla va a decanularlo y va a necesitar una noche con nosotros para medir saturación y ver cómo el niño respira cuando esté dormido, aquí, una noche, pero eso es más adelante.
So the second stage, so one stage is this surgery. The second stage is decannulating.
Okay.
Okay. Now, way back in the day, and still sometimes, we will do what's called a single stage. And with a single stage, they do the same surgery, but what looks different now?
The tube.
Yeah, so there's no trach.
Yes.
And the stent is the ET tube,
Yes.
and it has the balloon
Is the balloon of the cannula.
of the
Yeah.
ET tube.
Okay.
Yes, of the cannula. These patients, especially when they're little, they can't be awake because
Exacto.
they have they're intubated
Ajá,
from
okay.
above.
Esto lo ocupan cuando están los pacientes pequeños. La diferencia es que ocupan un tubo. El balón del tubo es el balón de la traqueostomía, es este. Es este. Y el stent es el mismo tubo. ¿Sí?
And so the ET tube is serving as the airway and the stent.
Ese tubo para vía aérea y el stent, o sea, es la férula de la cirugía.
And we usually have these patients, we say down and out, deeply sedated and not moving for 1 week.
1 week, yes. When I studied in Mexico, this technique
Yes.
yes.
And then they go back in a week, just like our 2-stage, and the surgeon looks at the repair, and if it looks good, they take the tube out. Either in the OR or in Boston, they come back to us with the tube, and Dr. Hartnick says, "It looks great, it's wide open, go ahead and extubate whenever you want."
Okay.
And,
Ellos
yeah.
lo hacen en sala de operaciones o cuando el doctor ve que todo está súper bien, dicen, tú le estubas cuando quieras.
And then it's a single stage because once this tube comes out, the patient is breathing normally and there's no trach, so it all happened in a single stage.
Okay.
Okay. So now there is the double stage and the single stage. This is what we're going to talk about, and this is what your patient is going to have. And we call it 1.5 stage. Okay?
Okay.
So
Our patient,
the same
this is
surgery,
our patient is
Yes,
this. Okay.
yes.
Okay.
Same surgery, right? Here's the narrowing, and they do, anterior and or posterior. But at the end, so these patients usually come in and they've been living with a trach. They leave a little small trach in here with no cuff. But the patient comes back with a breathing tube that's acting as the airway and the stent.
Stent, okay.
Okay? So why have this? It's safer because if for some reason this tube gets knocked out and the patient isn't intubatable, you could ventilate them through this trach.
Okay. Esta es la unión de ambas. Esta cánula no lleva este es lo que van a hacer con el niño que no va a llegar. Esta cánula no tiene balón, pero va a estar intubado. Es una cánula pequeñita. La razón de esta cánula es porque si el paciente se extuba accidentalmente, no lo vamos a poder intubar. Entonces su vía aérea va a ser la traqueostomía. Entonces, si el paciente se extuba, nos vamos a dirigir a la cánula de traqueostomía. If the cannula is closed by secretion,
So
remove
usually
the
it will
cannula?
be, yeah, usually they'll come back and there'll be a tegaderm over it.
Okay, but
If you need to use it,
yes,
you take this off.
o sea, van a venir con tegader, entonces va a venir sellada, pero si necesitamos ocupar, la vamos a abrir. But if the cannula is closed, or secretion,
Yes.
or
Yes.
blood,
Yes,
I-
if for
I
any
change
reason,
the
yes,
cannula.
yes, if for any reason you cannot ventilate through this tube, you would have to take the balloon down and take it out and use this. Now, if
Okay.
this is a mature stoma, you may change this to a bigger
Okay.
tube with a cuff
okay,
and put it in
una
and
cánula
blow the
con
cuff
balón.
up.
O sea que si se sale esto, vamos a poner si esto está tapado, ocupamos una nueva cánula con balón. ¿Sí?
Okay.
Y si la vamos a... I'm
No,
sorry.
go ahead, go ahead.
Y si está tapado por alguna razón y vas a ocupar la cánula, hay que desinflarlo porque si no, no va a pasar porque ocluye la vía aérea. Entonces tenés que desinflar los balones para ocupar esta cánula. Okay.
Leaving this in serves a second purpose. After the patient goes back to the operating room in a week and Dr. Bonilla says, it looks great, the patient will come back to the ICU with this out and with their original trach in.
Okay.
And they will go home just like this guy with the trach in place, do capping trials, and make sure that they breathe comfortably
Okay.
before this is taken out.
Okay, I have a question.
Mhm.
What the reason you use this technique and different?
So, it's a very good question. So I think I haven't had the discussion with Dr. Hartnick about that in this patient's case, but I think that part of it is that this patient is a very difficult intubation, and it would be very difficult to intubate from above in an emergency, and I think that has something to do with it, but I'll circle back to you because I don't know
Okay.
exactly why he decided to do it this way.
Yes.
Okay.
Because I think it's
This
too-
is
it's
the
too easy.
safest.
Yes, I think.
And when we first came to El Salvador, we learned this with you, that this is the safest.
Yes.
And we used to do these, and sometimes Dr. Hartnick would say, looks great, go ahead and extubate. And we would extubate, and the kids couldn't breathe.
Yes.
And it was awful,
Yes.
right?
This
And
technique
so-
in Mexico is too difficult to me a long time ago, 20 years ago, because some patient lost the tube.
Yes,
Yes, in ICU, and
Yes.
it's too difficult to
reintubate.
and maybe
Right.
make a new
Yes, a new trach,
a new trach.
incision.
Yes,
Yeah.
yes, it's too
So during that week of recovery, this is dangerous
bad
because if
experience
it
for
comes
me.
out,
Yes.
it's awful, right? So both of
difficult
these
too.
are safe. Well, but if this tube gets knocked out, you always do have
Yes,
that.
okay.
Yeah.
Okay, yes. This is different. Big difference.
Having this second backup airway is huge,
Okay.
huge. Also, these patients, they have to be sedated, right? And so a week of fentanyl, Versed, dexmedetomidine translates into, for us at least, another week in the ICU weaning off of all of that stuff,
Yeah,
right?
yeah.
So even though they come back to the ICU and Dr. Hartnick says, you can go ahead and extubate today,
Okay.
we often are not able to extubate that day because we want these kids wide awake, and that takes time.
Okay.
But we don't want them withdrawing,
Mhm.
right? So we can't just turn the medicine off.
Okay.
So
We
it's
need-
tricky.
We need this page. We need this.
I'm gonna give it to you.
Yes, we
Yeah.
need to put lo vamos a poner en la
Yeah.
cuna.
This is for you. This
Okay.
is for you.
Okay.
There's one other thing, if I may. So this patient comes back wide awake. So what about this patient, right? We just said it's very obnoxious to have this tube in place. If it were a little kid, 3, 4, 5, you would have to sedate them for a week. This patient, Dr. Hartnick thinks, he's 13 years old. He should be able to be awake. And I'm going to show you a picture of what this looks like. Because he still needs the humidification here. I'm going to show you the setup that we have
Va a estar
done.
estubado, I'm sorry, va a estar estubado. Con el ventilador humidificando. O sea, esta va a estar como que va a estar con el tubo aquí, con el humidificador, no va a estar intubado. Va a estar despierto, sí me explico.
It's going to be a nasal intubation,
Yes,
so it won't move a lot.
Ah.
But he's going to wake up. He's going to be probably breathing spontaneously when he comes to you with the tube hanging out of his nose.
Yes. Only use a mask with ventilator.
So it's going to be the same setup as,
yes. Así como estamos.
but not attached to the ventilator.
No está conectado. No
But
sé si me
just the
explico, ¿sí?
humidification.
Okay.
And then in 2 or 3 days, we can put an HME. Do you know the little sponge cap on, so
like
that
a
he
nose.
can walk? Like you know.
No, nariz le decimos.
Swedish
we
nose.
We say it's nariz.
Okay.
To
Yes.
to close the.
Vision and calm. Now, suctioning him every 1 or 2 hours is going to be very
Cada 2
important.
horas hay que estarlo aspirando y tocando el cuello cada hora. Rapidito, cuello.
All the same things we talked about here apply.
Okay.
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 One little complication that I learned about the hard way here a few years ago, we had a patient like this, and he kept having an air leak. I kept hearing that he had a leak, but his balloon was inflated, and I didn't think that it was broken. So why? And what we realized was that the trach, the ET tube had come back a little bit, and the trach now was pushing on the balloon and creating a leak. Does that make sense?
Sí. Como está el tubo, la cánula va a aplazar un poquito el balón y puede tener una discreta fuga. ¿Sí? Porque está la tráquea, está el tubo y está la cánula. Y esa cánula puede estar golpeando el tubo y hacer una pequeña fuga.
And what we ended up doing, we ended up advancing the ET tube just a little bit.
Okay.
Now you'll see that there's not a ton of room between the reconstruction and the carina. And so these tubes, when you get your chest x-ray on these patients, you're going to be looking for 2 things. You're going to be looking for pneumothorax, and you're going to be looking to see where this tube ends. When they put this tube in, they do it with a bronchoscope under direct visualization, and they place it in the distal trachea, but just above the carina. Don't adjust it. If you feel like they're main stemmed, let's talk. But it is different from your other patients where being in the mid trachea is the right place. These patients, it has to be pretty deep in the distal trachea.
Sí, ese tubo va a estar puesto por broncoscopía en la zona más distal de la tráquea, pero puede ser que se desplace. Si se desplaza, tenemos que hablar, ¿verdad? Es diferente a lo que se está haciendo en otros pacientes.
So I know that we've talked about a ton of things here, but we'll write it all down, and I think you're gonna be great, and we're gonna be available if we can be back here in 5 minutes. Our hotel is right down the street.
Okay.
And we'll leave you with the right phone numbers so you can call Evelyn. So she's Spanish speaking, and you can talk to her, and she'll grab us, and we grab a taxi, and we can come right back, and we don't mind at all.
Okay.
And we can look at patients together. If you think there's crepitus, if you think the tube is right main stem, if you think they're developing a pneumothorax, anything at all, you just give us a call. But we won't leave tonight until we all feel comfortable.
Okay.
Okay?
Ellos, por cualquier cosa, duda de ese paciente, van a estar dispuestos a que los llames en español a Evelyn. Ellos están a 5 minutos, están en el Camino Real, que están cerquita de aquí. Y ellos no se van a ir de aquí hasta que ellos sientan que todos estamos cómodos.
We're going to leave you with a number 5 LMA. That's what they had to use to get the tube.
Nos va a dejar una máscara de laringia número 5 para que la podamos utilizar.
Because
This is first I use the cannula.
Yes.
The second use LMA.
Use cannula either for a trach or an ET tube. You could put in a small ET tube, and if you can't for some reason,
Use LMA.
then you would have to, but that would be dangerous because now there's no protection from positive pressure.
Sí, es una salida más, pero sumamente peligroso ocupar la máscara laringe, pero la van a dejar, es como, yo creo que ya van a estar ellos aquí.
But with your patient breathing spontaneously, it is safer, right?
Okay.
Yeah.
Okay.
I think that's it.
That's
What
it.
what questions do you guys have?
Only one use this
Yes.
and now use
I
this.
will. I don't want to assume that I know what Dr. Hartnick's thinking. I'll circle back to you to
Okay.
make sure I have some guesses, but I'll circle back to you.
Okay. I come back to the hospital at 5,
Okay.
4:30, 5,
Okay.
5:30,
Great.
and I stay at night, maybe at 9, 9:30,
Okay.
and I leave to my home, and we talk with her.
Okay. So these are for you.
Okay.
I also will send
So
you
I'm
the PDFs, Dr. Guzman. I'll send you the PDF so you have the PDF like that.
Yes, I know the
Yeah,
PDF.
I'll send these. I have these
Okay,
as PDFs.
perfect,
I'll
perfect.
send them to
Okay,
you.
thank you.
Okay.
Thank you.
Okay. Now you know everything I know.
No, I thank you for the paper to.
Oh, did you have it? Did you look at it?
Yes. Very well.
The one on team training?
Yes.
That's a good one, right?
I
Yeah.
think use in every bed. In every bed, put one. It's very important.
Oh, do you mean like that? How to stand around the
Yes,
bed?
in one bed, one. In two
Yeah.
beds,
Okay.
another.
Great.
Yes.
Great.
Thank you so much.
But for the course that we're doing with you and Elias,
Yes, we use the
so
scarf.
we will give them that to read before they come.
Yes.
This
Okay.
is what teamwork, right?
Yes.
All the
I like it.
communication and all of that
Yes.
before the course. Okay. I'm glad
Thank
you
you.
like
Thank
that.
you so much.
Yeah, no, it's our pleasure. And then you have the 4 scenarios that I think your fellows were reviewing.
Okay.
And then the next thing we need to do when I'm back in Boston is practice the connection.
Yes. Okay.
And then whenever you're ready and you want to try to do the course together,
Yes.
we can schedule it.
Yes. We have a conference, a reunion.
Mhm.
The residents from Hospital Bloom
Mhm.
make a reunion in September, October. Maybe use this to show
Sure.
all El Salvador,
Sure.
and you maybe to connect to me
Yeah.
to El Salvador, Boston is a plus.
That'd be amazing.
Yes.
Yeah.
Do you agree?
Yeah.
Okay.
Yeah.
Okay.
Also,
Perfect.
in Boston, I found Spanish-speaking nurse, respiratory therapists, and doctors,
perfect.
and we made a video. And the first, we asked them to do a terrible code, where nobody's talking and people are yelling,
Okay.
and it's like 4 minutes, and then we have them redo it after we talk about that paper about communication and leadership, and and then they do a nice code. We thought for our course we would show the first and then ask the people in the course, what do you think? What was good? What was bad?
Yeah.
And to teach them about teamwork by having them talk about why it was so bad, and then show them, okay, the team learned from you, and this is them doing the code a second time
Perfect.
to start the course.
Perfect.
So-
Perfect.
Okay,
I talk with you in the future about this idea.
perfect,
Okay.
great.
Right.
All right.
Okay.
Yay.
Thank you so much. See you later.
All right,